Hi everybody, very excited to be here. So this session's called Digital Therapeutics. And I'll spend about 30 minutes kind of talking. Also, I recognize that there's a lot of entrepreneurs in the room here. So in addition to kind of sharing what we do, I'm going to pepper the talk with kind of little secrets that we've learned along the way in both kind of getting people through our program, making it work for people, and kind of navigating all the complexities of the healthcare system. So, I'll get into this in more detail, but broadly speaking, kind of the idea of digital therapeutics or digital medicine is using software and software experiences to actually get a clinical outcome, a measurable clinical outcome. And when you do that, you can commercialize it in hugely interesting ways. So hear me talk about that, and then we've got Peter Hames from Big Health is going to talk about that as well. Super exciting stuff. So for those of you who don't recognize the image behind me, this is actually, it's called the Ether Dome, and it's a room in Massachusetts General Hospital. And this is where ether was pioneered as an anesthetic for surgery. So as you could imagine, it's really hard to do surgery. If you can't put someone to sleep, it makes operating quite challenging. And they invented the way to use ether to actually knock people out so you could operate. And what it did was kick off this incredible wave of surgical innovation. It really kind of formed surgery as we know it today, in large part. In addition to that, obviously, the field of anesthesia. And this is an example of one of the first surgeries that was done under anesthesia that could never have been done before. This was a neck tumor that was taken out of a patient while they were under. This is in the middle of the 1800s where this happened. And in large part, this moment in technology, because anesthesia and the use of it, that's a technological innovation. It kicked off this transformational wave of innovation in surgery, and it led to a lot of what we see today. I think that we're having an ether dome moment for behavioral medicine. And behavioral medicine is a specialty of medicine, and there are people that practice it. It broadly defines to things like weight loss, addiction, depression, anxiety, sleep disorders, phobias, anything where there's proven evidence in the literature that shows that you can really help people in a high-touch way, work with them toward a clinical outcome and make a difference in their life. The reason that I think we're at an ether dome moment for behavioral medicine is if you actually try to unpack what works, like what's the active ingredient in behavioral medicine, what are kind of the key things that make a difference? In large part, it's social support, peer relationships, programmatic guidance. It tends to be a lot of the softer stuff. And if you look at how behavioral medicine is traditionally delivered in large part today, it's kind of it's in this setting. It's face to face. Super high touch, time intensive. You get a patient either one-on-one or get them in a room and bring them through kind of a process or protocol. And as mentioned, in large part, it's dependent on emotional relationships. In order to modify behavior, if you look at all the literature, you really have to have social components, and people need to feel supported and guided. And what's going on right now, of course, is web and mobile and just the way and digital experiences are being created in such a wonderfully rich fashion where you can create social experiences and you can create those set of emotional relationships, but on the other end of an internet connection. And this is what's really enabling this kind of new world of digital therapeutics. And it's quite simple. It's just instead of the pill that gets you the outcome or the device that gets you the outcome or the procedure that gets the outcome, it's kind of the software experience you create that gets you the outcome. And at Omada, we got very, very interested in diabetes. This is an area where there is a lot of behavioral medicine research to see how you can prevent people from getting diabetes in the first place and then help them once they have it. These are figures from the US. So, in the US, the epidemiology of diabetes is quite staggering. There are 85 million Americans that have prediabetes, which is where you can test their blood and see that the sugar levels are higher than normal, but they're not quite high enough to be called type 2. The scary thing about this is that people with prediabetes tend to convert into type 2 diabetes at a rate of about 5 to 10% a year. And a couple of months ago, the CDC came out with a quite staggering statistic that said that 40% of adults, given kind of our current diabetes trajectories, in the US, will find out that they have type 2 diabetes. That's 40%. So obviously that's something that we need to work on as a country, and it's a global problem. Diabetes is unfortunately a crisis everywhere. And so that's kind of doom and gloom, but what's the silver lining? It's that it's proven to be preventable. There are a number of studies that show this. In the US, there's one called the Diabetes Prevention Program, which was a landmark clinical trial. They took thousands and thousands of patients and they brought them through 3 protocols. The first was placebo, which in this instance it was handing people kind of the content from the lifestyle program and saying, hey, take this, go off and kind of do it yourself. Good luck, give it a go. They tried Metformin, which is a medication that's commonly used for people with type 2 diabetes. They wanted to see if putting someone with prediabetes on a regimen of Metformin could reduce the conversion into type 2 diabetes. And then they had a lifestyle intervention, which was really, you can think of it as kind of dropping in the paratroopers to help someone with prediabetes. So they brought them through a 16-session course, very intensive. They really, they would do everything for that person, knock on their door, try to help them in any way possible to improve their health. And lo and behold, the thing that worked the best, it was clearly not placebo, no surprise. Behavior change is really hard. It doesn't work to hand someone a pamphlet. It wasn't the drug, though there was a risk reduction with Metformin. It was the lifestyle program. And the lifestyle program reduced the risk of converting from prediabetes into type 2 diabetes by 58% at 3 years. And there are 10-year data that show even 10 years out, going through that kind of moment of lifestyle intervention, reduce that risk of that person getting diabetes 10 years out by 30%. So this was really, is an extraordinary clinical result. This is the sort of result where, if it were a pill and it was that good, it might have been commercialized, but it was a program. And what happened in the US, and really what kicked off our company, is that it made its way into Obama's Affordable Care Act. So the Affordable Care Act basically gave the US Center for Disease Control the directive to work to roll out and propagate face-to-face programs for people with prediabetes across the country as widely as possible. And their vision for this is crystal clear. They want to help create and foster a world where the second step for everyone who has prediabetes is being referred into a program. A program that is reimbursed by the enterprise healthcare system in the US. So that's the vision that they've put forth. We started talking to them, quite early after we caught wind of this. I was in medical school at the time, and then I was on an internship at IDEO. And their vision, which is not too uncommon in the healthcare world, was that this should be and could be done, entirely in a face-to-face setting. And so, getting people into community sites, YMCAs, primary care offices, just figuring out where to deliver this 16-week program in a group-based setting, because that is the best way to do it, across the country. And we approached them and said, look, we want to work to build a digital version, of this program. Interestingly, from a policy standpoint, a lot of stars in 2015 are aligning in the U.S. There's a legendary task force in the US that basically it's called the United States Preventive Services Task Force that really rates, it's kind of the consumer reports for preventive medicine. It kind of rates the quality of the evidence base behind them. They just gave a very, very favorable rating to these sorts of lifestyle interventions. And these sort of clinical recommendations, because they're actually tied to coverage decisions, can carry a lot of weight. So, the policy angle is aligning, but the delivery mechanism was lacking. Because with 85 million people at risk for prediabetes, it's challenging to get them into brick and mortar sites. It's exceptionally challenging to scale brick and mortar sites. Where do you put them? How do you staff them? How do physicians learn how to refer and to where? There's just a lot of complexities. So our vision with our first product, Prevent, is to take the evidence that the CDC had put forth and basically their guidance on how to deliver this sort of lifestyle intervention. They basically give you the recipe for it, to do it in a face-to-face setting. and kind of take that and do our kind of best job of translating that digitally, using a lot of the key things that work in a face-to-face setting, which in large part it's the stuff that I mentioned before. It's the social relationships, the peer accountability, the support. So our program it's quite high touch and it's multimodal, which I think we as a digital health industry will start to see more and more of. And it involves a lot of different interactions, which I'll show. But it's in a group setting, just like the brick and mortar programs. There's a health coach, there's a curriculum and a timeline. Ahead of the program, we mail people a digital scale that's cellular connected, web, mobile. It's really and we mail you other packages as you go through it. So there's really a lot of ingredients and a lot of instruments in this piece of music we're creating. But broadly speaking, just to give you kind of a sense of how it works from a participant standpoint, and then I'll talk to some of the elements that I think make it most successful. The whole thing is on a timeline. So we enroll people. At Omada, the way we enroll people depends on who we're working with in large part. So if we're working with a provider group, like a Kaiser Permanente or the VA, they just refer patients to us that are eligible based on the criteria of being pre-diabetic. If we're working with an employer in the US, a lot of employers will do pretty robust biometric screening programs. They'll offer that to their employees as a benefit. Sometimes they'll even incentivize it. So we'll work kind of as a second step to that data. Or there are risk screeners that you can use, which aren't perfect, but they give you a pretty good idea if someone might be at risk for diabetes. So we enroll people, we match them into groups, we kick them off on the core phase of our program, which is a 16-week program, where once a week we're unlocking lessons. And then after the core phase, we graduate folks into the sustain phase of the program, which is really ongoing. That actually does continue forever for a person. So right at the beginning, we've got to get you set up. So you apply, you enter some of the basic information so we can get you your welcome kit, which is kind of your first experience as part of the program. So you get your kit, and inside this welcome kit, there's a digital scale that has a GSM, a cellular chip in it. It's pretty neat. It works just like a Kindle. The patient or participant opens the box, they step on the scale, they hear a beep, they have an email saying that the scale's connected. We chose to take that route because the mean and median age of people in our program, currently it's actually in the 50s. And diabetes risk and prevalence tends to correlate quite strongly with age. And you want to make sure that things just work for a person. And I always kind of think about my mom. She's fine getting on the internet. She kind of knows she has that Post-it note that I helped her put on the desktop that points to that little globe thing that she's got to click on. She knows how to do that just fine. She can go to URLs, but she's going to have trouble pairing a scale to our Wi-Fi network at home or to her phone. I mean, she doesn't actually have a smartphone, but so it's you have to make it easy. We try to make it easy. So you get your scale, and then we put you in groups, and not just any groups. We match you into groups. So the goal in this group setting is to create groups where the participants have things in common with one another. And so the matching criteria that we use it's primarily threefold, though there are exceptions. But it's location, and it's age, and it's body mass index. And if you think about it, it makes a lot of sense because the goal is to make this feel more like a real kind of face-to-face experience. And if you know that someone's maybe in your city or your state, you'll just have kind of a little bit more cultural empathy for that person. And then if you see them being successful in your group, you'll think to yourself, well, that person's kind of like me. If they can do it, I can do it. So that's location. Then we also match by age. You're in a totally different phase of life. If you're in your 50s relative to your 30s, you probably have different reasons that brought you to where you are in kind of your health trajectory. And you want to make sure that the group members can empathize with one another on that dimension. And then body mass index, because if you have a BMI of 41, you're going to have a different experience going through our program than if you have a BMI of 27. Different trajectory of weight loss, different emotions as you lose weight, and frankly different needs. And the group supports one another, so you want to make sure to address that. So we get you in your group. We kick off a timeline of 16 weeks. which you can kind of see at the top there. There's the dots that run across the top, so those are the weeks. Right at the beginning of the program, we set a common weight loss goal of 7%, expecting between 5 and 7. And everyone shares that goal. And then what we do is we show progress toward that goal around each person, but nobody knows each other's real weight. All right, so if you're Denise, you can see kind of in the green circle that goes around Denise. If you're Denise, you're maybe you're getting close. You're about a third of the way there. And if you're looking at Beatrice in the bottom row, you can see that Beatrice is about halfway there. And you can feel inspired by Beatrice. You can see other people's progress. Human beings are creatures of like peer comparison, and if you allow that to happen in a subtle, supportive way, it can really move the entire distribution of outcomes forward. So that's a really positive and interesting dynamic. People report to us that they'll log on even if they've done their curriculum, if they've done their lessons, they'll log on literally just to see how others in their group have done. But it needs to be normalized, and it needs to be on a timeline. And so for the entrepreneurs in the room who are working on products, even outside of healthcare, one of the things that surprised me the most in building Omada is it's really this kind of power of peer reference points on normalized metrics, whatever the metric is, on a specific time window. You have to have like those kind of three things, like peers that you care about, a time window, and normalized metrics. Like those three things are a recipe for social engagement in a whole host of products. That's not just healthcare. You even look at like a good deliberately straying from the healthcare course. A good example is a company called O-Power. This is a U.S.-based company. They mail you an electricity usage report that compares your usage to your peers. Incredibly successful company. They just maybe they just went public or they filed, one or the other. And the dynamic is that exact same thing because the time window is last month, right? So you have the time window. You're already matched, right? You have peers that you care about. You're in the same neighborhood as them. It's competing with the Joneses. It's just the classic, you wonder what your neighbors are doing, right? And then you normalize the metrics so you can compare your usage to them. So that works for us. It works in a lot of products. It's a very kind of tried and true way to get outcomes. And it's actually what happens in a face-to-face program as well. So you're in this group setting. You've got your health coach who's doesn't ever meet you in person, but really makes sure the group is safe and kind of guides people through the curriculum and is less of a teacher and more of a facilitator, really. In fact, originally we wanted to call this person a facilitator, but health coach felt a little bit clearer from a user standpoint. And then we kind of carry you through the experience. So we've divided the curriculum into 4 phases, and each phase lasts about a month. And critically, we actually mail you packages at each phase in the program. So we send you something in the mail at phase 2 that ties into the content from phase 2. It kind of breaks the fourth wall. It makes it feel a little bit more real, given that the end goal is to make this feel like a real experience. And people love that. People like getting stuff. It's just kind of a classic dynamic. And then at the end, we create this moment of celebration where you're now a graduate. It's a super exciting moment. You're with an alumni community that's kind of created around your health coach, and there's you're with just more people, and then we continue to release curriculum and work to do our best to make the software experience even after the core phase valuable to the person. And it totally works. It's really neat to see the. If you look at the employer wellness space, in large part, it hasn't, done well, at least in the U.S. There's a big RAND study that showed that the average, employer weight loss program from like an employer-based, wellness initiative is basically 0. Usually that's, taking, kind of a step counter or like a Fitbit and just kind of giving it to people. Additionally, and I love, huge caveat is that I think this is an awesome product and some of our participants in our program use it, but there was a MyFitnessPal trial that just came out and they randomized people. Docs recommended some people use MyFitnessPal to lose weight and didn't give anything to the others. This was published in Annals about 2 weeks ago, and there was no difference between the populations. So you really do have to dive in with someone and have a very high-touch intervention. The red line is what you see in these brick-and-mortar DPP translations. That's kind of there's a big review of kind of how they tend to do. We've published 2-year data benchmarking our program against the CDC standards here, and we met them all. We published that in the Diabetes Educator. We're about to publish 2-year data, which are looking great. We have thousands and thousands of patients and participants from our commercial partners. We're getting to kind of past year 1 data with them, and the results have held right where we want them to be. And no program's perfect. There's only, it's just, you have to kind of really go all in with someone to get to a good outcome. And thus far it's been working. And this is kind of the key. This is kind of the key point. You have to have data. It was so tough for us to even sell into any enterprise without proof and some data. I mean, you can't go talk to the medical director of a health plan and convince them to test your product or work with you without some evidence that it might be successful. I think there are really 3 key elements for companies like us who are trying to commercialize behavioral medicine in a scalable way. And, the first is you have to do it reproducibly. Again, that feeds into the data piece. You have to constantly watch your outcomes and making sure that you're able to reproduce your outcomes in various populations, and there's reliability in it in the same way as a pill has reliability. You kind of know that when you're giving a bottle of Metformin out to people, the Metformin is likely to act. There will be variances based on genetics, et cetera, but it's likely to act in the same way. So it has to be reproducible. Otherwise, you won't be able to commercialize it. Cost effective. There are tons of economic analyses in the space around diabetes prevention. So thankfully, we didn't have to reinvent the wheel there. We kind of leverage existing kind of data. But I think that behavioral medicine of the future can be extremely cost effective. It's not cheap to do in-person behavioral medicine. That costs a lot. Single visits can be in the hundreds of dollars for a plan or provider who's carrying a risk. And then scalability, right? These things will be built to scale. They can be built to scale. These are some of the key things that I think can bring this world of digital medicine, digital therapeutics that's emerging now to the next step in the future. Just to highlight some examples, so you're about to hear from Peter, one of my favorite companies in this space. It's so cool. It's basically there's a tried and true way to help people with sleep disorders and insomnia, called cognitive behavioral therapy. He's kind of digitized that. There's a company called Lantern that's working in the depression, anxiety space, and this is a new company. It's very early, but I wanted to kind of talk about this one because I know it blew my mind, and I think it'll blow yours. The gold standard treatment for phobias, like clinical grade phobias, right? Fear of flying, and these are debilitating phobias, is actually exposure therapy, and it's slowly exposing the patient to these phobias. This company, Fearless, this is my friend's company. He's an Oculus Rift developer, and he's building exposure therapy on Oculus Rift. And for any of you who've tried Oculus Rift, it's mind-blowing. It absolutely tricks your brain. You actually feel like you're in a different world, and this will absolutely work. Like, there's no doubt in my mind. Like, this will work. And also the cool thing about this is if you think about kind of the subclinical grade phobias, like mild fears of maybe public speaking that some of you in this room might have, or fears of getting on airplanes. This can be helpful with that, right? So this is where tech is it's expanding kind of the reach of tried and true interventions, because there's such a barrier to looking up in your Rolodex who might be the right psychologist or psychiatrist to go to address something that's like just subclinical. So it's a really exciting time for the space. I mean, we're at the very beginning. When we started, there weren't too many people publishing data, and investors are putting money in the space. These are some of our backers, investors that hadn't worked together or working together. And at some point there will be one or multiple kind of you can almost think of them as therapeutics companies for digital health. Cool. Well, thank you all.